Good afternoon, my name is Ben Davis. I lead the axial spondyloarthritis rehabilitation course here at the IUH. And I've got a presentation really about how we moved this service online. However, I had nothing to do with moving it online. I've worked here for 3 months, so all the people who are up on the screen there, who are physios, OTs, medics, admin team, nurses, were the people who, through the pandemic, moved this course. And I will describe to you firstly what the condition is, and then I'll describe to you the nature of the course and some of the processes we have to think about for getting this process, getting this maintaining some aspect of rehabilitation for this cohort of people online through the COVID pandemic. And then some thoughts about how we might carry on some aspects of this digital sort of agenda beyond. Thanks, Don. Whether you know much about axial spondyloarthropathy, firstly it's quite a mouthful to say, so we'll call it AxSpa, it's a bit more accessible. It's a part of an inflammatory spinal umbrella term, so people with this condition can present with a range of problems, predominantly spinal stiffness, so the inflammation is affecting the joints in the spine is becoming increasingly stiff, pelvis has become increasingly stiff. So that inflammation, of course, is systemic, so it affects extra-articular manifestations, meaning potential for eye inflammation, for gut inflammation, for skin inflammation. So it can affect people in a range of ways. Particularly the impact or potential for ulcerative colitis and inflammatory bowel diseases. This is a comorbidity that's really, problematic for people to manage. Fatigue is often a function of lots of these inflammatory problems that is less described or less talked about than the obvious things such as pain, but fatigue is a big problem for people, and this is cognitive fatigue, physical fatigue, poor sleep, dealing with a complex long-term condition. So it understandably has impacts on people's moods. People will be more worried, people will be more stressed about the future, people will be depressed to some degree about the impact this has on their life. And skin inflammation I've mentioned. So AxSpa has a plethora of symptoms and comorbidities that come with it. Done. It usually presents in our 20s to 30s, but unfortunately there is a relatively long lag to diagnosis, because if you can imagine, the main sort of symptom presentation is back pain, and hundreds of people present to primary care with back pain every week. There can often be quite a delay until this diagnosis becomes formalised. NAS, National Patient Group, are really pushing a very active social media campaign to try and bring this understanding from primary care, from private providers, private physios, chiropractors, osteopaths to understand, to the patient, the public to understand, actually if you present with back pain plus these symptoms, you should perhaps flag this up with your GP a little bit earlier. The IUH have recently been accepted onto part of the NAS program called Aspiring to Excellence. This is going to look at our processes, look at our delivery of rheumatology and therapy in rheumatology to try to reduce this diagnosis, this delayed diagnosis, and therefore improve outcomes. One of the key things in the last, I think it's about 15 to 20 years, that has revolutionised inflammatory conditions as biologic therapies. That has revolutionised the progression and prognosis for people with this condition. However, it by itself isn't sufficient perhaps to ameliorate the problems. So for many years we've run a residential Living with AxSpa course at RNHRD, the Mineral Water Hospital before, and then as that's moved up to the IUH. Thanks, Tom. So this course includes very good looking people in a hydrotherapy course. That's typical for our course. Daily hydrotherapy, daily stretch and exercise sessions. And these exercise sessions can be mobility based, they can be yoga based, they can be Pilates based. We also bring exercise sessions that are around HIIT training, so some strength and conditioning, because sarcopenia, loss of muscle mass, is another aspect of this problem. And the third part of the course is education sessions, which includes across 2 weeks, what is this problem? we help both clinicians and patients to be able to spell spondyloarthropathy and some of the medications that they may be taking. But we look at fatigue. We look at fatigue. We look at the role of exercise and you know, how we might think about somebody factoring in daily exercise into their daily routine, which if you think of the age group, could well be working age, could well have family, could well have normal life stuff outside of their condition that they're wanting to live well with. So we have OTs involved to talk about fatigue and work issues, how to perhaps liaise with your employer to have reasonable adjustments. We talk broadly alongside our psychology colleagues around stress, the biopsychosocial impact of these long-term conditions, and how to bring in appropriate low-level CBT, cognitive behavioural therapy type techniques, relaxation techniques, mindfulness-based techniques. We work with podiatrists to understand the risk of foot problems and how somebody might flag up those issues for themselves so they can get earlier advice and intervention. We have sessions from the nurses around the biologic therapies and the role of other medications such as anti-inflammatories. And we have a role around research because there is a huge amount of research in this area. So we want people to understand what it means to be involved in a trial, what it means if they're getting information from their primary care network or from NAS and others. We try and help people understand and want to give back into that research agenda. So that's a 2-week course. That's what it sort of looks like. COVID comes along, and we, being an evidence-informed, learning from others, people looked for the research into how to move stuff online. And it's the cart before the horse because there is essentially nil evidence as to how you should and what to consider in terms of any aspect. If you think of the practicalities, and there's no evidence about how you should move this kind of course online. I was previous to this job, I worked in community paint services for local community providers, and so I'm aware of research like this. Jackie Walumbe and his colleagues looked at this is early in 2020, so they did a review in 2019. What is the evidence for putting on pain management programs? So not AxSpa specific, but the principles and philosophies exactly the same, and there was nil evidence. So we're really working from clinicians, trying to be sensible, but also what the team here did was to work with BIRD, who are the Bath Institute for Rheumatic Diseases. BIRD do a lot of patient public involvement. So working with BIRD, the team here could reach out to people with the condition. I could have shown you Gantt charts and project management documents around focus groups with people with this condition, around focus groups with clinicians. We kind of co-created or co-thought about what could be useful from this existing curriculum. Obviously, you can't really do hydrotherapy online, but you can do exercise online. So how would we bring that into this new online course? The challenges though, and you can imagine, I'll ask you all to think about how you aim to keep contact with people in those early days of the pandemic, how you schedule Zoom calls, the technical problems you had with Zoom calls and Teams pub quizzes with your friends and family. It wasn't the most simple thing, was it? So if you go on, our challenges we had to think about were, what would be the IT platform? Working for different providers in the last couple of years, IT and IT governance people seem to have different views on Zoom as a free option, Zoom as a paid-for option, Teams as an option, AccuRx group consultations as an option. What were the organisation's preferences? What budget perhaps did you have to spend? Did this platform require a relatively high-level degree of technology? Claire was just talking about access to the kit is not as simple and universal as you might imagine. And you shouldn't be assuming that someone who's older doesn't and someone who's younger does have access to IT equipment that's suitable. So we have to think about these issues. We have to think about, if we are going to ask people to move, how do we do that? What's the risk of somebody, you don't want to see John in the corner of his living room taking a tumble, and landing on his bum because he's doing some exercises by himself in his own home. How do we risk assess those exercise programs? How do we make sure the patient is happy happy and confident to have the sufficient space around them? What kit do they need, such as a chair, such as some weights, such as a timer perhaps? What if something does happen? How will we risk mitigate the risks of asking someone to do physical exercise when we're not there present? We probably not even in the same county, sitting on the same room. Thank you, Donnie. We had to think about managing a group. What we knew from the course, having run here for many, many years, that cohorting of people together, that sharing of experiences, those coffee time conversations were critical in people understanding they were not alone with some of the issues that they would bring, or they would be experiencing that maybe they wouldn't bring to the course until someone else mentions that they experienced something similar. So how do you manage the group? How did you keep everybody interested in the topic that was at hand? If it wasn't quite appropriate to that person, but it was to this person, how did you keep that appropriate privacy? How did you keep that appropriate consent to have conversations? How did you keep those sessions moving forward? How do we aim to keep the group as informed as possible? So what should our handouts look like? Were these PDFs, were these Word documents? Did we ask people to print out something that was 60, 70 pages with lots of links? If you print it, then you can't follow the hyperlinks. Lots of these things that you're just having to work through, and this was all part of the planning before launching and piloting this course. I think there's one more. The course has used, and AxSpa services around the country use existing outcome measures, one of which I'll just pick on, the BASME, Bath AS Metrology Index, meaning 5 movements. How far forward is your head from the wall as a measurement? How far can your neck turn left and right? If we measure your spine when you flex forward, and how far side to side can you bend? And how far apart can your hips go if you can measure between your ankles? How do you do that if you can't see the person? This is our most used measure for, trusting this is still working. This is our most used measure for measuring the impact on patients' mobility. We experimented, my colleagues experimented with photographs. Could they photograph themselves, send them in? Could we measure ranges? Can someone scan and spread their legs to measure hip movement? If they're lying on their back, how do you take a photograph from above themselves? Can they lie on the floor? We did experiment with all sorts of these things to a greater or lesser degree of success. So all of these things were the challenges. This is what the course looked like in the end. This is a 2-week course condensed down to 1 week. We built in group chat time. We built in some free time through those 3 days where people could just be online and they could just, having got to know each other in the first couple of days, have a bit of a chat, a bit of a social time. It wasn't always clinician led, or we might be around to facilitate discussions. We ran these drop-in sessions. My colleagues ran drop-in sessions, you can see, early in the morning. So if someone had something they wanted to just, catch up with, they could have almost a one-to-one Zoom time before the majority of the day started. Colleagues produced their PowerPoints. Some colleagues produced videos that we had. So if Deb Bond, who's a specialist in biologic therapy, we could link people to the video that Deb had done on biologic therapy so people could hear her talk, see her talk through her presentation, even though she wasn't there all the time to ask questions and answers from. So we condensed this. Obviously the stuff that's gone from there in the 2-week course is the hydro and a greater degree of stretch sessions as well as exercise sessions. Moving on, looking back through all the files we've got, I wanted to try and sort of see what evaluations we had, and this is really as much as I want to present in this forum. There was a range of experiences in the post-course feedback. Some people loved it, and I think today this will be some of the stuff that we carry on with into the future. Some people found the online forum not needing to travel, not needing to be here in Bath, it could be at home, not needing to make major childcare arrangements, or actually they found that much more accessible. Some people really found the online delivery to be accessible, to be appropriate. They could still feel like they were part of a group. The feedback that we got was very beneficial. but not everybody. Some people really, we all know what it's like to be on Teams calls for a long periods of time through the day, or to be online for long periods of time in the day. We're wanting people to move, yet we're asking them to sit in front of a camera for prolonged periods of time in the day. The philosophy is almost wrong, isn't it? So not everybody found this useful. Not everybody found it was accessible. People did have IT issues. They had Wi-Fi issues. Calls would drop out. So there was a range of experiences really present in that forms part of the learning. And I think almost when I look at our waiting list now and what people want, there's around an 80% of that waiting list want to do something face to face. 20% of people will opt for a virtual course out of their preference, and that's for those points that we just made. I suspect it's easier for them to get time. It's easier for them with, overall life management. Looking forward, though, and this isn't really just about the options for delivering these kinds of courses online, but how do we move and use technology more to a greater extent? This morning I was at a research meeting at Bath Uni, and lots of these are projects. There's projects looking at, can machine learning interpret MRI scans earlier and quicker than radiologists? So similar to the breast mammogram work in breast cancer, you can teach machines to pick up the cancers, the tumours quicker than perhaps an earlier stage than consultant radiologists do. Can there be a machine learning process to understand, to pick up these conditions earlier that might get missed currently? There's work going on in virtual reality, so that means the whole Oculus headset where you're immersed in virtual reality, but also augmented reality, options to kind of put your spinal movements overlaid on top of reality, a bit like Pokemon. I don't know what Pokemon is, but it's the best example of augmented reality. Thinking about problems with the BASMI measurements, there's research into using phone sensors and phone capture, motion capture processes that exist to be able to use these BASMIs or produce these BASMI measurements remotely. So that would allow people to self-monitor, either using the processing power of the phone or to send photos or videos into a central computing hub that would be able to make these calculations and provide ongoing self-evaluation of their mobility processes. We have moved PROMs, patient-reported outcome measures, online. We use iPad options. We work with Meridian as a company who can facilitate patients accessing their data remotely and putting in questionnaire data remotely. And I think really interesting is Project Nightingale, which is a project where someone's using that data, that patient-reported outcome data. Can we do two things? One is work out you're heading for a flare. So flare is a term where your symptoms are flaring out of proportion. Can that be taught to learn that for you, actually, that reduction in your sleep quality that you've described over the last couple of weeks, you're likely heading for a flare? Can we link you into a reminder about sleep hygiene strategies? You said you're getting stiffer. Can we link you into an online exercise reminder? So can we almost lead into behaviour change techniques that are patient-led and under the control of that person, rather than waiting until their next clinical appointment? Yeah, that's fine. Last slide, I think. But the questions around all of this technology-enhanced option, whether it's the virtual course, whether it's some of these other sort of future researches, for who is the course most appropriate? Can we articulate to people in clinic that we have this option and be clearer about the sort of pros and cons, so that people can self-select when they do feel confident, when they do know they've got the IT, when that fits with their life better? Can we get an element of self-selecting? Can we use some of these technologies to enhance this delivery? So can we use, if these apps for BASMI measurements come around, become reliable enough and valid enough, can we use those to enable us to evidence how useful that virtual course is? Does this allow us to increase our capacity? Can we get to see people if we can deliver them face-to-face sessions, but then we can almost give them homework that is recorded, that is online, that is YouTube video, so we can kind of almost condense that course down. It doesn't necessarily need a clinician delivering it, but maybe then get a clinician Q&A the day following to answer questions or issues that were raised. Can all of this help enhance people's behaviour change, meaning People have to own this condition. They have to be able to know how to self-manage with clinician input to support that as required, as is acceptable. And of course, all of this needs further sort of validation and research, both quantitatively, so can we measure your spinal stiffness, but qualitatively, how did this feel to be involved in a process that's very different? Did this feel to be useful for you? If not, why not? And how will we evolve and refine it and deliver it in an iterative process so that it becomes part of our armoury, part of our toolkit for supporting this group of patients to live well with this condition. Thank you very much.
Well, that was really interesting.